Hi, this is Brad Power, and this is the Cancer Patient Lab. We're very honored today to have Bob Gatenby with us. This is the third time he's been gracious enough to spend time with us. In previous sessions, he shared his experience with evolutionary biology and game theory and the way that they use their models to develop a strategy for cancer care. I first heard of Bob, I think it was Marty Tenenbaum or someone pointed out he was interviewed with Peter Attia and got a big coverage from that. But he was very useful in helping both Brian McCluskey and Bryce Olson think through their approach to bipolar androgen therapy and their strategy generally. He's a leader in the adaptive therapy approach, which manifests itself as bipolar androgen therapy in prostate cancer, which are the subjects of previous sessions we've had, and you can see those notes and video recordings for that background. Today, what I've asked him to focus on is updates and things that he's learned over the last year or two, and the insights that he's gotten with his approach. In my experience, Bob is the only person I know who's bringing a strategic approach to cancer treatment decisions. The default implicit premise of most doctors is maximum tolerated dose until failure. And it's typically one thing. So the notion of combinations, of sequencing, of personalized dosing, all those strategic things are things that Bob introduces that I see rarely, if at all, anywhere else. And so he's a leader in that area.
True.
Not true? Okay. Who wanted to challenge that?
Sorry, I didn't realize my mic was on. I'll challenge that.
Okay.
We frequently see doctors adjusting chemotherapy doses per responses. So if somebody responds badly, they may lower the dose. They may change the timing of the dose. They may go from 3 weeks to 2 weeks with a slighter dose. That's in academic practices. So I would say you make a good point, but it's not true to say we never see it. We do see it.
Well,
Okay.
may I comment on that? So the dose adjustment, so the general principle is really to do the maximum tolerated dose, as Brad Power said. And most of those dose adjustments are usually as a result of side effects, often due to bone marrow suppression. So I think what Brad said was actually quite true.
Okay. I don't want to start the conversation here. I was just trying to do the stage setting.
You have a combative group here, Brad.
I know. That was hopefully the stage setting for Dr. Gatenby. And then also, just let me quickly cover the housekeeping, then I'll hand it over to him. There are 3 typical things we say at the front here. This is for information purposes only. We try to bring information to patients and caregivers so they can take it to their medical team. This is not medical advice. Second, everything here will be made public. If you're concerned about your image being made public or what you say, turn off your camera, change your name, and don't say anything. And then finally, we are a nonprofit 501c3, and we depend on the kindness of donors who help us keep our operations going so that we can bring you webinars like this. And with that, I'll turn it over to Bob.
Thank you. Let me try to share my screen. This is always the most complicated part of it. And then I need my glasses to see what I... Okay, can everybody see this?
Yeah, you probably want to do the...
I'm sorry,
there you go.
This is not the right one. Excuse me. I'm gonna stop sharing here again. Try again. Here it is. Okay.
Quick answer to Chase's question in the chat. This is set up so that Dr. Gatenby will speak for about 5, 10, 15 minutes, and then we'll have the lion's share of 45 minutes or so for Q&A.
Can you see my screen now?
No.
Okay, sorry. Let me try again here.
There you go.
Okay, let me try here again. So this is just an update. And what I'll try to do is just do a brief overview and then get into what we've learned recently. Um, the basic premise here is that increasingly the cancer death is the proximate cause of cancer death is evolution. When I first started working in oncology a long time ago, there weren't that many drugs available. But what's happened in the meantime is that there's been many drugs that have been developed, but the death rates from cancer have not changed very much. And the reason is because cancer cells have access to the whole human genome, and in the process can evolve resistance rather quickly, or often very quickly, and very effectively. So this is a typical example. This is one of the new targeted agents that's treated for EGFR mutant lung cancer. It's very effective. And then what do we do? Well, we keep giving erlotinib, and eventually the tumor progresses. If you think about cancer as a game, and this is the cancer treatment over time, between the oncologist who plays the game by applying a therapy, and the cancer which plays the game by evolving a resistance, the oncologist actually has two major advantages. One is that he or she always plays first. That's the equivalent of playing white pieces in chess. This is called the Stackelberg game, and it gives an inherent advantage to the person who's leading the game. More importantly, I think, is that the oncologist is sentient. The oncologist can anticipate what the cancer is going to do and plan for that. Whereas, like any evolving population, the cancer cells can never anticipate the future. They can never adapt to something they have not seen before. The problem is that when we use the standard approach, which is maximum tolerated dose continuously until progression with some adjustments for toxicity, we're still playing, basically the oncologist is playing the same move over and over again. At each cycle, it's the same thing. The cancer cells can simply respond as they have before. There's no additional burden placed on them. And because the oncologist changes treatment only when the cancer progresses, the oncologist has ceded control of the game to the cancer. And so very much what we want to do is have the oncologist playing a far more active and informed kind of game. So this is the evolutionary kind of demonstration of what happens in maximum tolerated dose. You start with a population of perhaps a small number of them have some ability to be resistant either inherently, or they can develop resistance quickly. You give maximum tolerated dose and you get a great response. It's very impressive. But in the process, you're sowing the seeds of your failure, because what you've done is that you've put intense pressure for resistance, and you have eliminated all of their potential competitors, and so you can just keep repeating this, but all you're getting is sort of steady tumor progression. This actually has a name. This is actually a well-known dynamic in evolution. It's called competitive release. And to be honest, it's hard to do something worse than this. This is from an evolutionary point of view, nearly always unwise. So our approach is, and again, there's many types of evolutionary treatments, but this is the one that we've used in prostate cancer. Here we apply a treatment instead of just, with the goal of eliminating all of the cancer cells. Our approach shifts from the cells that are sensitive to the treatment to the cells that are resistant, because those are the ones that ultimately dictate the outcomes. And so our goal here is not to kill as many cancer cells as possible, but to in fact maintain a significant population of sensitive cells with the goal of using them to control the resistant tumor cells. So here we apply a treatment, but rather than maximum tolerated dose, rather than trying to kill as many cancer cells as possible, we deliberately leave behind a significant population of cells that are sensitive, and then we stop treatment. during this period of time when there's no treatment, there's also no selection for resistance. And in general, there is a cost of resistance. In other words, they have to develop the molecular machinery necessary for that. That cost is exceeded by the benefit in the presence of treatment, but in the absence of treatment represents a cost with no benefit. So in this case, the sensitive cells have a fitness advantage. And so what you do then is allow them to sort of grow back. And what you do is sort of recapitulate the population distribution that you started with originally. You can treat again, it will restore. You just keep, and so this is a kind of a cycling therapy. There's a this is the idea here is not passive. It's to use the treatment as a forcing function, and if you apply it at the correct time, you can induce oscillation, generating a near steady state. Our first trial was in abiraterone. We've presented this before. There's about a 28-month difference in overall survival in the adaptive therapy group. The adaptive therapy group did not receive any treatment at all, 46% of the time on trial, and that resulted in a cost, on average, a cost reduction of $70,000 per patient per year. 2 of these patients are still, of our adaptive therapy patients, are still cycling stably after about 8 years. So this actually was not what we predicted in the model. In other words, we did not think they could do that many cycles. And so again, it points to the fact that our models are good, but they're not perfect, and we need to keep working on them. Now, since that original trial, the standard of care in castrate-sensitive disease has changed, because now it's based on the Latitude trial. It's now abiraterone added to androgen deprivation therapy. In this case, however, it's continuous administration at maximum tolerated dose. The initial trial in the New England Journal had a median progression-free survival of 33 months and a median overall survival of 53 months. We have not reached the median time to progression. So again, this is that kind of adaptive therapy on-off switching. In fact, 3 more patients have to progress to get to a median time to progression. None of them have had PSA progression, and they have to have radiographic progression to be off cycle. So it cannot be less than 68 months, and that's median time to progression. So we will more than double the median time to progression of the standard of care. And importantly, these patients receive no treatment at all, 54% of the time on treatment. So more than half the time, these men have normal testosterone levels, which significantly improves the toxicity. And since they receive abiraterone less than a quarter of the time, abiraterone, which is a very expensive drug, that significantly reduces the cost. So this is where we are with this right now. It's sort of a weird situation, because the results are so good that we can't report it because we haven't reached a median time to progression yet. But that said, we've tried to use what we want to know now is, what about these guys? What about the men that progressed early? Can we understand those dynamics, and can we intervene in those? Let me see. I'm sorry, I will point out one more thing, and that is, this is not terribly surprising. This is a man who has developed his own androgen deprivation therapy adaptive process, who's now 13 years into this with a Gleason 9 metastatic prostate cancer. So this is the fact that we're seeing very long-term stable disease is not necessarily that surprising, but we still don't know exactly how common it is. And looking at this, what we found is that that we have a biomarker for tumor progression, and that is the ratio of PSA to testosterone. In this trial, unlike our first trial with abiraterone, we have 2 general lines of data over time. One is testosterone level and the other is PSA. They're always drawn together. And so what we've been looking at is that what we find is a predictor is that the PSA to testosterone ratio begins to increase as the men develop more and more resistant disease. And so that's our biomarker, but it also suggests a different dynamic. This is the model that we used to start with the abiraterone trial and for the androgen deprivation trial. But I think we made a mistake here, and that's this. We assumed 3 populations, all based on their interactions with testosterone. T plus cells are the ones that require endogenous testosterone, and these are ones sensitive to ADT. The TP cells are the ones that produce testosterone and so are sensitive to abiraterone. The T minus cells we thought were going to be entirely independent of testosterone, that these would be there would be no androgen dependence at all. What we've learned, what the PSA to testosterone ratio suggests to us, is that these cells are actually able to proliferate in lower and lower levels of testosterone, castrate levels of this testosterone. And so this goes to a kind of a different mechanism of at least initial progression, and that is that you are seeing high expression of androgen receptors. And you can see here, this is an example on the right of that kind of dynamic and how you can see it tremendously upregulated. What's interesting about this mechanism is that what we know about it is that while they're very good at continuing to proliferate in low testosterone concentrations, sudden increases in testosterone cause a hyperstimulatory state, which induces apoptosis. So this kind of gave us some suggestions that maybe we can engage in what's called directed evolution. So for centuries, humans have used directed evolution to promote desired traits in domesticated animals. Can we do this type of approach in the prostate cancer as they transition from castrate sensitive to castrate resistant? And so we have the models to deal with this. This is the first patient that we've tried this on. I'm just going to go left to right here. So this is a person who had been on standard dose of ADT, went on to an adaptive cycle, and it went through several cycles. But you can see that as the testosterone is off, you start to see this increasing level of PSA. So we see it in 2 cycles. So for us, that's PSA progression. What we then did was kind of a modified BAT in that we injected testosterone. Here, the specific purpose is to kill the resistant population because we have this sudden increase in testosterone levels, which induces apoptosis, and at the same time promote the population that is what we call the T plus cells, the ones that require sort of physiological levels of testosterone. So the goal here now being to change the dominant population so that we can bring it back to a cancer population that is sensitive to androgen deprivation therapy. In this case, this individual had a variety of neurologic underlying diseases and could not tolerate any of the standard therapy for castrate-resistant cells. He could not even tolerate abiraterone, none of the chemotherapies. So we felt that this patient had the only thing we could do is essentially try to do a directed evolution approach so that we could restore sensitivity to androgen deprivation therapy. So now here are 4 cycles in which we injected the testosterone. Now, unlike BAT therapy, in which the injection of testosterone or the administration of testosterone is timed, is rigidly kind of kept according to a couple of months. Here, each of these was based on the subsequent of the response. So we had an initial tremendous increase in PSA with the injection, came down, and then as soon as it went back to kind of baseline, we did another injection. Notice the PSA went up again, but much less than this. And then third cycle, much less than this. We interpreted this to mean that the hyperexpressing antigen receptor prostate cancer cells were initially responding tremendously, but also dying, so that population then grew smaller and smaller. And you see on the fourth one, the PSA went up slightly at its peak. We interpreted that to mean that we are now essentially stimulating the standard, the T plus cells, the ones that require physiologic testosterone. And we felt that we probably had then transitioned the populations. And so we went back onto cycling ADT. He's now gone through, I think, 6 cycles of this, and we're now sort of back to the adaptive ADT. So we sort of restored that castrate sensitivity level. And this is our third generation trial, which has already accrued, I think, 6 patients. It just opened recently. And this is kind of when we initially talked about using mathematics to guide clinical cancer treatment, this was kind of our goal. In this trial, every patient is going to go through an initial cycle, and that's going to be used to parameterize the models. And from then on, the mathematical models will be used by the oncologist to optimize outcome at each new treatment step. And so with that, I will stop sharing, and I'm happy to have a discussion.
Wow, that
So-
is just
so-
great.
Bob, can you start with what you just shared? How is that different than what you would have shared a year or 2 ago? What's new?
What we've a year ago, so 12 months before this, we knew that the median time to progression was in our second generation trial was pretty good, but now it's way above anything that's been done before, and we know that it's going to be at least 6 years and probably 7. So some of these very long-term survivors on adaptive therapy and androgen deprivation therapy, it's now looking like they were not as unusual as we thought. And the second thing is that we've learned that the mechanism of resistance, at least early on, and we're not quite sure how often this is, but I think it's pretty common, is an epigenetic state in which they've upregulated the androgen receptor so that they're highly upregulated. It's not a genetic thing, it's an epigenetic thing. But what we've learned then, I think, is that we can kill those guys, and that we have this kind of directed evolution strategy that is working. And so we actually have a trial which is about to open, where we explicitly are going to try to do this conversion therapy. I think that if we can use this sort of initial adaptive therapy approach and get 7-8 years of control, and then when there's progression, have the ability to move them back to the beginning, I think we can effectively eliminate prostate cancer as a cause of death. So it's a chronic disease at this point, but because the patients have normal testosterone more than half the time on treatment, the level of toxicity is significantly reduced. And because abiraterone, which is a very expensive drug, is only given less than a quarter of the time on treatment, the expenses are going to be greatly reduced. So anyway, that's kind of one of the things that we're exploring a couple of ideas, such that, for example, in the adaptive and androgen deprivation therapy, the on-off, we rely on the patient's own testosterone levels to come back up. What we've learned is that that can be, in some men, a very slow process, and that's probably a mistake, because it's in that, as it's coming back up, there's a prolonged period where it's still pretty low, and that's actually promoting the hyperandrogen receptor population. So what we're doing now, and I think what we'll do in the future, is that if the upregulation, if the upsweep of testosterone is not rapid, which is what we really need, we're going to have to do it on our own. We're going to have to use a patch or something like that, so that we have a rigid control of the testosterone concentrations. I think that we've developed that. I think it's been a little too passive in the way we've been doing it in the past, but of course we didn't realize that sudden upsweep was really important. And when we go back and look at the patients that were that have been very prolonged response, that they all had this rapid upsweep at the beginning. So we know that much about it. So so I think we've learned quite a bit. And I mean, I'm reasonably confident that we can maintain even terrible metastatic prostate cancer, you know, as a stable chronic disease with a very high quality of life. I mean, not perfect, because you're not on, you know, the testosterone levels are still going to be very low, you know, not quite half the time, but you know, but still, I think on the whole, this gives us an opportunity to really say this disease, we can end this disease as a cause of death. I believe we're at that point.
Okay, we've got some folks who've raised their hand. Let me just ask one more question, clarifying question before we go to the raised hands. And that is, Bob, you've several times referenced we. Could you describe your team and the resources you're bringing to bear to do your analysis?
Sure. So yes, thank you for mentioning that. I usually have a thank you slide at the end, and I forgot to do that. So Jinsong Zhang is the oncologist, the prostate oncologist who has run these trials and will run our the conversion trial. Sandy Anderson is the mathematician who has been working on this project, and he has a number of junior faculty members that will work with him. Joel Brown is an evolutionary biologist who has worked with us. So the team is oncology plus math plus evolution. I'm not sure I mentioned this, but at Moffitt has the largest mathematics department of any cancer center. We actually have 13 faculty mathematicians. We also have 2 faculty evolutionary biologists. And so that multidisciplinary kind of approach is built into the infrastructure now. We have a cancer biology and evolution program. We have a center of excellence for evolution-based clinical trials. And we have an evolution tumor board, which which includes mathematicians and evolutionary biologists, although it's run by an oncologist, with the idea that we can, for individual patients, provide some guidance to the oncologist about how to optimize therapy.
Thank you. Okay, Bill Passman, you have your hand raised.
Yeah, so first off, I want to congratulate you on such great work. I mean, I've very seldom seen a treatment regimen based on a solid mathematical and biological basis as this. So that I want to, you know, you should be congratulated on that. That said, I don't have prostate cancer. I've got kidney cancer. And I was wondering what other kinds of cancers this thing is being applied to.
We have actually 2 trials in renal cancer going on. One has been just a so what I showed you here was we sort of have a dual treatment. In the case of prostate cancer, we've largely focused on the cost of resistance. An alternative is to focus on the mechanism of resistance. And so in that case, you give one therapy and you anticipate the evolution, the adaptive response, and then you give a follow-on therapy that specifically targets the evolution, the evolved mechanism of resistance. And so that's what we've been doing in renal cancer. And we have one set of patients who have had prolonged responses to a single sequence of treatments. And a second trial, which is just about to begin, is more of an adaptive therapy trial, similar to what I've shown you before. I'm happy to just offline speak about this if you want to hear more.
Great. I'll send you if your email address, I guess, is available from Brad.
Yes.
Thank you very much.
Yeah, sure.
Thanks, Phil. Chase, you're up next.
Dr. Gatenby, just want to thank you for your work. It's I just thank you. A couple small things. Abiraterone is now available as a generic, so you can get it for like $26 a month.
Okay, that's good. That haunted us in that first trial. The cost was tremendous.
Yeah. So I'm working with Dr. Jang, Zhang. You pronounce it like a J, Zhang. So his and I live in Washington State, but you are the only guys who have any hope for me other than just like, we'll take this till it doesn't work anymore. So I've been seeing Dr. Zhang. The piece that is difficult for me is determining what is my actual dosing. Like, I understand the concept. I want to keep some sensitive cells around, and I want to but how do I actually figure out? I've been using Erleada and dutasteride, and do I go for like, do I take it for 3 days or do I take it for 1 month? Do I take, how is that determined?
We try to use the metric of response in the case of prostate cancer, PSA, as our kind of guideline. Now, as I said, we've added testosterone to that, which I think has been very helpful. And there's two ways to approach this. One is what I showed, kind of the adaptive therapy on-off. You give a treatment, you wait till the PSA goes to about 50% of the pre-treatment value, and then you stop, and you just let it come back. When it goes back to the pre-treatment value, you start again. So you just keep going on and on with that. That's pretty much everything that I've showed you so far. There's an alternative approach, which in our preclinical experiments was more successful, and that is that as you start to see the PSA or the whatever the tumor marker is going up, you apply a therapy at one point with the goal of plateauing it, making it just not necessarily pushing it down, but just keeping it flat there. And then from then on, you can increase or decrease the dose of drug at each decision point based on what had happened before that. So if the PSA goes down a little bit, you reduce the dose. If it goes up a little bit, you increase the dose. And that's called a dose adjustment strategy. That was actually the better strategy of the two in preclinical experiments. But it's very hard to do in a clinical setting because it requires constant decision making, and oncologists don't terribly like to do that. That said, Michelle Lockley is an oncologist in the UK who is doing this with ovarian cancer, and she repeated our experiments, and now she has a very active trial going on where she's using that dose adjustment strategy to maintain a tumor control. And so we'll see how that plays out clinically. It's probably not necessary in prostate cancer because the problem in the preclinical setting was that if you had a very aggressive cancer, like a triple negative breast cancer, in these on-off cycles, you ran the risk of losing control of the tumor. It could blow up so quickly that it was, it just got too big to do anything about. So that was why we used that. Prostate cancer is probably not that, in most cases, not that aggressive where that's really a huge problem. Did I answer your question?
Yeah, that is the question, so I don't want to turn this into a treatment for me, but just like my PSA doubles every week. So I've been taking my PSA and I let it get up to like, say, 50, and then I take a few days of medicine, and if I go like 3 or 4 days of medicine, it'll come all the way back down to say 5 or 6.
Yeah.
And then I can be off it for 3 weeks or something like that. This is essentially the
yeah, that's
the
more or
idea.
less what we see. There's there's two things to think about. One is the maximum. There's no particular evolutionary problem letting the maximum number go up higher. you don't, I mean, you could stay with that, but as long as you're not having symptoms, you can let it go up higher. The reason is that the more time you give the treatment sensitive cells to grow, the more they're suppressing the resistant guys. The tendency though, the biggest tendency is to overtreat. And we as we analyzed our first trial, that's what we found, is that you really, you remember the treatment sensitive cells are your friend, and you want them to take care of your enemies for you. You don't want to eliminate that population. So if you push it too hard though, the more the lower that population is at the beginning of the next cycle, the bigger problem you have in maintaining control. So you don't want to go down too far. Now there's a caveat to that, and that is what we think is, and didn't realize at the beginning, was that the upshoot of the testosterone is very important. You can tolerate going lower if the upshoot of the testosterone is very rapid. If it's not very rapid, then we either need to cut off the dose at a higher PSA level, or you need to start taking testosterone at the trough so that you get the sudden surge. It doesn't have to be an injection. There are patches that can be used. The point is that we want to get to physiological levels as quickly as possible when we decide to stop the ADT.
And what is rapid? Is that like a week, or is that a month? Or
No,
is it...
that's a couple of days. And so, and this is what we're finding is this is very highly variable.
Yeah.
But testosterone does not go up really quickly, but I mean like overnight, kind of quickly. The problem is that because the resistance mechanism, the upregulation of the androgen receptors, is an epigenetic mechanism. It means it's not hardwired in the genome. It's the expression piece of it. If you give those guys time, they can downregulate the as the testosterone level is going up, and if it's going up slowly, they have time to downregulate the expression of the androgen receptors, and so you're not getting that killing effect that you want. Because the goal with this is to boost it, just overwhelmingly simulate all of their androgen receptors at the same time, which then induces apoptosis. So that timing seems to be very important.
So just to restate, you want you're following testosterone levels, and at the ADT, the testosterone comes down, but you want it to recover quickly within. Now, a normal testosterone level is like 250 or something. So you want it to come back up to normal within a few days?
Yes. I mean, that would be ideal. Now, if you,
okay.
And again, it's, it's surprisingly it's surprisingly variable. But
yeah.
Yes,
yeah, I mean but that's the whole point of what you're doing, is to try to figure out on an individual level like what you need to do. So you're taking you're following the ADT for just whatever time it needed to bring it down, and then come back up in 2 or 3 days. Okay.
Yes.
I don't want to monopolize. I have one last question, which is, finding. I've watched your every YouTube you got, and I'm trying to find you on the web as much as possible, etc. Do you have like most of the things I've seen, you are presenting to a new group of people for like 1 hour. Do you have like a 5-hour thing, or do you have something where you have worked with your team and you're recording something that like gives the whole where can I find the most information about what you're doing?
If you send me, we had a article in Nature Review Oncology that is a fairly long and was meant to be fairly comprehensive review. I do have an article coming out in Cancer Research, just as this is a much shorter review, but is a commentary on Michelle Lockley's papers. So yeah.
Okay, so I email
about
you
1 hour is my limit.
Yeah. Well, I mean, what you're doing is super interesting, and I'm just trying to I can't find anybody who will help me like figure out what my individual thing is aside from Dr. Zhang, who's wonderful but a long ways away from me.
Sure. I work with a physician on the West Coast who is a private practice physician, but works with people, and our group does sort of an informal collaboration with her. So if that does, her name is Dawn Lemon, Lemanne.
And that's, if I could interject here, that's a good segue to Jeff Krolik, who is a patient of Dr. Lamont and Dr.
Yes.
Gatenby. So Jeff, could you maybe share a little bit for Chase's benefit and others' benefit what your experience has been from a patient's point of view adopting these methods? You're on mute, Jeff.
Yeah, after some consideration and discussion, I work with Dr. Dawn Lamont. She strongly recommended using an adaptive approach. So we have, she consults regularly with the team at Moffitt Cancer Center. Occasionally, we do, I guess you would call it like a tumor board via Zoom to discuss. I would say for me, the most important part that I had to make an adjustment to is very consistently getting almost weekly testosterone and PSA labs. So the rate of increase in both of those and decrease and symptoms that I'm experiencing or not experiencing can be taken into account. Now my insurance will pay for that. I have a lab very close to me, so it's easy to do. And sure, sometimes I might go 2 weeks without a lab, but that seems to be a key in individualizing the treatment based on my rates of increase and decrease and symptoms that I'm experiencing or not experiencing. But I like it because it does give me, at least periodically, a testosterone boost. I did have to get used to a higher PSA. The goal is not to squelch your PSA to 0.001. At certain points, my PSA is up over 100, and then it may go down to 50. But as long as, from my perspective, I'm not experiencing more symptoms, and occasionally we throw in a PSMA or an MRI scan just to see what's going on. This is the treatment that I feel is the best path for me going forward. And we have rolled in some supraphysiological testosterone along the way when it looked like I was starting to have more of or less of a hormone-sensitive population, and that seemed to be able to do a reset. So anyway, that's my experience. I like it, and I will continue with it for as long as it seems to work.
Dr.
Just for
Gatenby,
Chase's,
Can I throw in a couple of questions?
yeah. Let me just comment that Dawn Lamont is physically in Oregon,
I
and
see
Jeff's in
that.
Oregon, so she's practicing, and I think she can also practice in maybe New York and California or something like
I'm
that.
in Washington State.
Could I, could
Okay.
Is
I,
there a high,
could be-
is there a limit to the high PSA, or is that
Can we-
highly?
can we
some
go
people
back?
do 1,000 or?
Can I throw in a couple of questions that are applicable to more people before we do focus just
Go
on
ahead.
individual cases?
Go ahead, Paul.
Hi, I just want to get a couple of questions in that's not an individual focused on my treatment, but about the concepts behind this, Robert. The cycling of androgen receptor number and activity, of course, is central to this, with low on ADT or abiraterone or both, androgen receptor increase in activity and number, and that makes it primed for the next dose of high testosterone cycling on BAT. But then after a few weeks, I believe, the uh, androgen receptors get downregulated, and so the cycling is actually necessary to cycle high and low androgen level receptor activities, and along with that, CMYC, the big driver of cancer, is also cycled high and low, which is interesting. Question is, how long does it actually take? I've been guessing 3 to 4 weeks of ADT or androgen block is sufficient to restore high androgen level activities to prime for my next cycle of high testosterone. And by the way, I use very high testosterone. I use 300 milligrams of T-cypionate every week until I'm 5 weeks out for my ADT cycle. I switched to T-propionate. Thanks, Russ, for that information on that, so that I can have a rapid drop going into ADT. That's one. Second, last question would be, abiraterone is sometimes used without ADT because it's very effective all by itself. It's at suppressing testosterone levels. Is there really any need to have a luteinizing hormone drug in addition to abiraterone? Thank you, sir.
Sure. In my opinion, abiraterone is not necessary as in ADT. We had it in our protocol only because that's become common practice in the United States. I doubt that it's necessary, but it's hard to deviate too far from common practice in these dosing schemes. It's what we don't know is could fill volumes, and so how quickly cells can move back and forth from in terms of their androgen receptor regulation, go from very small to very large, is not something we know. One of the things, so physics for centuries has had empirical data and mathematical theory together, and one can inform the other. We don't tend to do that in oncology or medicine, but this is an example of where the math model is telling you we really don't need to know this. So you guys in the experimental world need to measure it. And so far I have not seen that, but you get but you're exactly right. This is what the one thing should be informing the other. The goal is to work together with the experimentalists so that we can work things out, as opposed to the current strategy, which is to kind of throw everything at the wall experimentally. We get mutations and this and that, and I think that's without underlying theory. We need, that's where AI we need, because that doesn't, you get so much data, you can't deal with it. So that connection is something we try to do.
Okay, Paul, you're good. Just picking up a couple of questions in the chat. Alan Morris, you've posted a few things there. Do you want to choose one and raise it here?
Can you just read them? Because I was slammed at the last learning session for suggesting that physicians know about liquid biopsies in the minimal residual disease state. I know that's off topic. This group, this prostate cancer advocacy group, which is a patient advocacy group, is incredibly pro the concept of superphysiologic bat testosterone therapy. And then segging that with the concept in cancer that the earlier is the better, which is true for many cancer treatments. They have gone off the guardrails of mainstream medicine and have done N-of-1 experiments on themselves, including in the biochemical recurrence phase. I'm going to go, you started me on a long diatribe, and I'm going to get crushed by everybody because everybody's pro superphysiologic bat on this this thing. But I will try to ask a question. It turns out Demede, who's the leader in superphysiologic bat, actually indicates a subset of patients that are most responsive. Admittedly, it's for resensitization to testosterone. And those are the ones that are the most advanced, not only in the advanced state of metastatic castrate-resistant prostate cancer, but those that have advanced genomic biomarkers, specifically, tumor mutational burden, BRCA positive, all these things that are incredibly advanced. And so the danger, I mean, the conventional wisdom historically was that testosterone was gasoline for prostate cancer, like you shouldn't do it, right? Don't you think there's a danger in doing superphysiologic testosterone on a cancer that I'm going to characterize as genomically indolent, which I believe most early biochemical recurrence patients are, especially if their PSA doubling time is greater than either 9 months or 15 months or whatever the cut point is for low risk BCR? I know that's a complicated question. I'm sorry for jumping in because I'm going to get slammed. So I'm ready for the onslaught.
Okay. Well, let me say, I would never have thought to give testosterone had it not been for the bat therapy literature. I would have just thought that was just incredibly dumb. So I appreciate that, and I think I'm with you on that one. And it was only the fact that there was good literature to suggest that we won't kill somebody with increasing the testosterone level. And again, this is a very controlled kind of process. The math models tell us this is when we want to give the testosterone. We are at a point that the PSA to testosterone ratio is telling us that this is a significant population that's increasing in size. This is the basis for progression on ADT. And so in this case, what we want to do is a limited sequence of testosterone, not 3 months. You'll notice that what we did was that when the testosterone went up and it came down, exactly when it came down is when we gave another dose. It's not a timing thing. It's a single dose, and it's a sequence of 4 doses given consistent with the underlying mathematical models.
Would you ever consider, here I'll state it a different way, would you ever consider giving superphysiologic testosterone, whether in the form of that or any other way, in a patient whose PSA doubling time is greater than 15 months?
You have to look at the models. I mean, that's what we do. That's why God made mathematicians, as far as I'm concerned. So every one of, all of these patients have models associated with them, and they're followed. We look at the rate of rise as one of the things we'd have to, I'd be interested in knowing what the testosterone looks like. We can estimate the underlying evolutionary dynamics mathematically, and then simulate the activity of a testosterone injection to see if that would be beneficial or not. I do think that whether we're able to do this in a large number or not, I think it will remain to be seen, which is why we have why we're starting a clinical trial on it. And that's all I can say. I wouldn't, given the hypothesis, I wouldn't touch that person unless we had mathematical models showing us what we need to do.
Alan,
Okay.
I would just add that my PSA doubling time is quite a bit less than 15 months, and it's been quite successful for me. So it's really individualized and not okay, here's what we do for everybody. And so far, so good.
Yeah, Mr. Krolik has his own math model, and so that's always sort of simulated at every kind of meeting. We come with that, but we don't actually do it in front of him. But behind the scenes is a fairly quantitative approach, and that kind of precision is what we think we need in this. And Mr. Krolik has a very complicated story. I mean, he was on ADT for a long time. I think it was like 18 months continuous. So he's a good example of how that continuous high dose treatment will tend to eliminate the treatment sensitive population, which we need to maintain it. So he didn't have a lot of cycles before we started to see progression, which is what we expected. The fact that we could not go with really anything that was typically used for castrate resistant made him, we felt ethically that we were okay. And of course, he was extensively consulted on this, that the approach, although we had not tried it before, was reasonable.
We're coming up to the hour, and I know you're on vacation, so I don't want to. I want to respect your
Actually,
time. Do
I
you,
have Dr. Lamont has a patient to discuss in 1 minute from now. So
okay, there we go.
and
So we will wrap up. I like to allow the discussion leader, this is you, to wrap up by having any final words of wisdom or any major key messages you want to leave with us.
no, I think I would just emphasize that we need to be the typical cancer therapy is seat of the pants almost. It's intuitive. And one of the things that we know about complex dynamic systems, which is a mathematical description of cancer, is that there's nonlinear dynamics, and intuition is human intuition, which is linear, is not really good at those kinds of things. So I do want to emphasize the need to have formal mathematical modeling to make any of these decisions, especially if you're going to do something that's really kind of far from the conventional treatment.